Sangeetha ma'am, you can start the presentation.
Thank you. Good afternoon, everyone. This is Dr. Sangeetha. Today, my case presentation is Mrs. X, aged 36 years, homemaker, and Mr. Y, 42 years, working in private sector, residents of Bangalore, came to hospital with a history of secondary infertility of 10 years duration, menstrual history, attained menarche at the age of 13, regular cycles of 30 to 35 days of 4 to 5 days, moderate flow, not associated with dysmenorrhea. Marital history, they're married for 14 years, first marriage for both partners, non-consanguineous marriage, no contraceptions used. A sexual history, frequency 2 to 3 times per week, no history of dyspareunia, no history of premature ejaculation, both were aware of fertile period. Past history, wife has a history of rheumatoid arthritis and presently on treatment, husband, nothing significant. Previous treatment history, couple have undergone one cycle of IVF in 2014. Number of oocytes obtained were 10. PISA was done in view of azoospermia. IVF ICSI was done. Frozen embryo transfer was done. Beta HCG positive. Pregnancy turned out to be biochemical pregnancy. Personal history, nothing significant. Family history, history of diabetes in both the families. Drug history, nothing significant. Physical examination of wife, height 152 centimeters, weight 77.9 kgs, BMI of 33.7, pulse BP normal, cardiovascular system, respiratory system, breast, spine and thyroid were normal, her abdomen soft, non-tender, her speculum, cervix, vagina healthy. Husband examination, height 168 centimeters, weight 91.5 kgs with BMI of 32.1. Pulse, cardiovascular system and respiratory system normal. Coming to investigations of wife, baseline day 2 LH levels were 8.55, FSH 8.88, 87, AMH 3.52, TSH 1.26, prolactin levels were 20.52, normal hemoglobin and PCV, GCT was 123, normal lipid profile. Baseline scan, uterus normal, bilateral ovaries normal, antral follicular count on right ovary 8 follicles, left ovary 9, normal diagnostic hysteroscopy, TB PCR negative. Husband, CBC was normal, GCT was done on 2 occasions, 87 and 104 milligrams, lipid profile and LFT were normal. Semen analysis was done in 2020, volume 3.5 ml, count 0, motility 0, azoospermia. His thyroid TSH was 1.74, FSH 10.4, LH 7.13, and testosterone was 324.49.
Dr. Sangeetha?
Ma'am, too. Yes, ma'am.
You only have put up the questions, so you yourself answer. So
Yes,
first tell only the features, like she is 36 years and he is 42 years, right?
Yes, ma'am. To summarize.
Summarize.
Yes, ma'am. A wife aged 36 years and husband 42 years with the secondary of 10 years.
Yeah, that biochemical pregnancy, you are, for that reason, you are calling it as secondary infertility, right?
Yes, ma'am. Yes, ma'am.
Yeah. So married like 14 years, once they underwent in vitro for IVF and
yes,
10 oocytes were obtained.
Yes, ma'am.
And it was done with a PESA sample. We don't know about the fate of the oocytes, right?
Yes, ma'am. Yes, ma'am.
So 10 oocytes, once frozen embryo transfer was done in that biochemical beta HCG positive. So we don't know how many, like what was the fate of all those 10 oocytes, yes, and how many were transferred, how many remaining, how was the fertilization cleavage, nothing we know to assess the PESA sample also to judge, yes, right?
Yes,
okay.
ma'am.
Okay, fine. So she is 36, 42 years. He is Azu. Yes. And only once this thing is 20, one sample 3.5 ml. Okay. Her BMI is on the higher side, right? 33.
Yes, ma'am.
Slightly on the higher side. And yes, baseline hormones also LH is on the higher side,
higher
right?
Side. Yes, ma'am. Yes,
and AMH is also 3.5. So PCO basically.
Yes, ma'am.
Okay. So husband is Azu.
Yes, ma'am.
So in this case, you are going to discuss in with respect to male infertility.
Yes, ma'am.
So how you want to proceed in this case?
Ma'am, in this case, male factor evaluation to be done, ma'am. By history, it looks like obstructive azoospermia. Since
How? Why?
ma'am, since sperms were retrieved from PISA during previous IVF cycle, ma'am. Should find out from the history whether he had any previous genitourinary infection, any prior surgeries done, medical history of any antibiotics or antihypertensives, any therapeutic agents, any trauma to the testes, or history of any anabolic steroids, and also examine, look for the secondary sexual characters of the male husband, ma'am, like hair distribution, any normal voice changes are there. And apart from the complete blood count and FSH testosterone, I also like to do prolactin levels to rule out prolactinomas causing azoospermia, ma'am. Then scrotal scan and scrotal Doppler to be done to rule out, to see the size of the testes and to rule out varicocele, ma'am. And fructose test for during semen analysis. If there is no fructose, then it is obstructive. If there
But
are
anyway, telling no, it is obstructive.
yes, ma'am. And examination of the VAS difference to be done. If VAS is not palpable, then it is congenital bilateral absence of VAS, ma'am. Then genetic test for CFTR gene mutation to be looked into. And if VAS is palpable, it could be either ejaculatory duct obstruction or suspicious of retrograde ejaculation. If it is retrograde ejaculation, then post-ejaculation urine analysis to be done, ma'am. If ejaculatory duct obstruction, then transrectal ultrasound to be done. There could be seminal vesicle or ejaculatory duct cyst, which can be removed transurethral resection, ma'am.
Yeah. See, in 2020, his semen analysis is done. It is 3.5 ml, right? With no
Yes,
sperms. So we are
yes.
going to repeat the sample. So we have repeated. Consider we have repeated the sample and it's almost the same. Okay. So
Yes,
if
ma'am.
the volume is less, around 0.5 ml, so what you will do? What you suspect?
It's an obstructive azoospermia.
If the volume is less?
Retrograde ejaculation.
Yeah, rule out retrograde ejaculation or collection problems also.
Spillage and all.
Any retrograde ejaculation.
Yeah, retrograde ejaculation and collection problems, right? If improper collection also. Okay, if retrograde ejaculation, yes, post ejaculation urine examination, look for the presence of sperms. Okay, in this case, we'll assume that it's the same, like around 3.5 ml with azoospermia, with no sperms. So how we are going to evaluate further? You have evaluated. Okay, you have taken the history, you have examined everything. Okay, we'll diagnose with obstructive azoospermia only. We'll think as it's grade 3 or grade 4 varicocele. What you will do?
With the backup PISA sample, ma'am, controlled ovulation to be done for the white, ma'am.
Grade 3, grade 4 varicocele as the reason for obstruction then?
Ma'am, grade 3 varicocele surgery may not result in normal semen analysis, ma'am.
Yeah. So even if we do the surgery, the semen parameters may not improve. So better to go for, if they're going for IVF, better to go for surgical aspiration methods. Okay. Then, if there is absence of VAS difference,
Oh, ma'am. Yes, ma'am. If
you told me the answer before only. Just
yes,
I'm
ma'am.
asking. Yeah.
If absence of, then it is congenital bilateral absence of VAS difference. Genetic test for CFTR gene mutation to be looked for, ma'am. Even if there is a CFTR gene mutation, ICSI can be offered or donor insemination, ma'am.
Any corrective surgeries can we do?
there are some micro surgical techniques through which
Yes.
through which blocks at the vaso, like the vas can be, if we can diagnose the point of block, we'll be able to, usually the point of block will be somewhere at the entrance at the epididymis or somewhere near the vesicles, seminal vesicles. If the exact point can be located, then maybe some microsurgical techniques can be tried, but availability of the techniques and success rates are low. So
Very
usually
low. Yes.
not many people go for it.
That is true, because we have the other methods, simple methods like PESA test and all those things. That is why we don't prefer, but there are techniques like we
And
can do.
even if we go for microsurgical techniques, we have to offer them that we have to preserve, we should do PISA so that we, if after the correction of surgeries, we are not able to collect the sperms, so that we have a PISA sample for IVF.
Okay. Okay. So same thing. Azoospermia. Okay, we have done. Okay. Then what about the other evaluation like hormones, FSH, LH, prolactin, testosterone, karyotyping?
Inhibin B can be added.
Inhibin B. Okay. Initially, we have to do FSH and testosterone only. If it comes abnormal, then we can go for other tests. Otherwise, if it is normal, means not necessary, basically. And karyotyping and Y chromosome microdeletions has to be done. Because previously they have done one IVF with PESA. We don't know the fate. I told you, we don't know the fate of oocytes. And it has only given biochemical pregnancy, right? We don't know the quality of the embryos also. Yeah, that is one thing. So we have to rule out, because azoospermia, almost 14 to 20% are associated with the genetic abnormalities also. So do a karyotyping and Y chromosome microdeletions. If it is normal, then go for the trial PESA or PESA sample and IVF, right?
Okay.
Yeah, Dr. Sangeetha, continue.
Ma'am, if we find out somebody has Y chromosome microdeletion and we are offering them PISA and going
We
ahead with
don't
IVF,
offer.
a Y chromosome microdeletion, ma'am, if they have
We
that.
don't. Yeah, we'll always take the genetic counseling opinion.
Okay.
And even if the PESA sample was positive, we get motile sperms. If there is abnormality with these things, we usually don't offer. We always ask them to go for the donor sample.
Okay, ma'am. But
Donor
if the
sample
patient
IUI or
but if the
IVF.
patient, okay, ma'am.
Yeah,
But if the patient insists that their semen should be used, and if it's ASFC where sperms can be retrieved and obtained, is sex selection possible so that only female gametes, PGD and sex selection of only female gametes can be done, and can that is legally allowed, ma'am?
I don't think so.
Okay.
Can go for PGD, PGS, actually PGT. But sex selection, whether legally allowed, means how can we say?
No,
It's
ma'am,
not
because
legally.
it is a medical condition wherein Y chromosomes are having the issue. So
Yeah, we
selected
have.
female embryos can only be transferred to avoid the genetic. If is it legally allowed? Because
No, it's not legal in India.
Yeah.
okay, even for genetic conditions also it's not allowed.
No. Maybe we can tell them we will do this PGTA. We will transfer the euploid embryos like that.
Okay, ma'am.
And that way it will be able
Instead
to
of-
break the hereditary transmission
Yeah.
also.
Yeah.
Okay. Then
But you can't put on papers, no, ma'am. That is what.
that no, we can't. We cannot.
Yeah, that's the thing.
Yes,
Dr. Sangeetha.
yes, ma'am.
Yeah, where are we?
Ma'am, coming to the wife, ma'am.
Yeah, okay. So now this patient, okay, male factor infertility, azoospermia, we think that everything is normal. We are going for the PESA sample, right?
Yes, ma'am. Yes, ma'am.
Okay. And PESA sample, we got motile sperms. So his sperms are ready now. Okay. How to stimulate the female now, right?
Yes, ma'am.
If PESA sample comes negative, then there is no other option. If her tubes are fine, then we can go for donor IUI. Otherwise, we can go for IVF with donor sperms. That's a different picture. Now we'll take it as PESA sample is normal. Motile sperms we got. So we'll go for the stimulation.
Yes, ma'am.
So-
For stimulation, ma'am, we should take a detailed history about her rheumatoid arthritis status and treatment, ma'am. Any
No, she will be, see, as I already told you, probably yesterday, rheumatoid arthritis, she'll be on steroids and anti-inflammatory drugs only. So that's not going to affect our outcome or stimulation, right?
Yes, ma'am.
So fine. The thing is, she is 36-year-old and BMI is 33. Yeah, like AFCs, though this thing is AMH is 3.5 PCO picture, but the AFCs you have written as only 8 and 9, just adequate reserve.
Yes, ma'am.
So what protocol we are going to start for stimulation?
Ma'am, she can be started with short agonist protocol or antagonist protocol, ma'am.
Yeah, I prefer antagonist protocol.
Yes, ma'am. On the day
Because of her AMH 3.52.
Yes, ma'am. On day 2, baseline evaluation is done, ma'am. H levels and E2 levels are done and baseline scans are done. And
okay.
Groupings are started on second day.
Yeah, Dr. Sangeetha, you see her LH is 8.5. If day 2 LH comes again more than 8 or more than 7, what we are going to do?
Ma'am, pre-treatment with OCPs for 1 or 2.
Yeah, we can actually pre-treatment with the OCPs, or sometimes we give, you know what, on day 2 we'll give just one shot of antagonist.
Okay, ma'am.
And day 3 we'll repeat the LH. If it comes less than 6, we'll start the stimulation.
Okay, ma'am.
It usually comes less than 6. One shot of antagonist, either in the luteal phase of prior cycle or on the day 2 of present cycle, and start from day 3 stimulation.
Okay, ma'am.
Okay, high LH can alter the outcome. That's why.
Okay,
That is 0.25 mg cetrorelix, no?
Cetrolin, yeah. And it's 0.25 milligrams subcutaneous stat.
Okay, ma'am.
Okay.
On day 25 of previous cycle or on second day of the cycle, ma'am.
Or second day of the cycle, yes.
Gonadotropins are started on day 2, ma'am.
Day 2 or day 3.
Day 3.
Okay. Day 3. So based on her weight, that is BMI is 33, and we'll take it as like PCO state only. So we will start with
225.
225 is ideal. Lesser means for her BMI it may not be adequate, right?
Yes, ma'am.
Okay. So 225, you know the stimulation steps, no?
Yes, ma'am.
Yeah, tell Dr. Sangeetha.
Yes, ma'am. And on 4th or 5th day of the stimulation, scan is to be done, ma'am, and see whether follicle has reached the size of 12 to 14 mm or E2 is around 300 to 400 picogram. Then start the antagonist on the same day. 0.25 of cetrorelix started till trigger, ma'am.
So usually like 3 to 4 days stimulation will give. A few of us might prefer on 3rd day doing scan and repeat the scan on 4th day, because sometimes there can be early recruitment and growth. So that time we will see on 3rd day itself, and then 4th day, or continue till 4 days and 4th day scan also, depending upon the follicular response, do the E2 LH. And then if E2 is more than or equal to 350, start the anti or the follicular size, as you mentioned. Fine.
And depending on the LH level, HMG can be added. 75 IU of HMG can be added.
Yeah, minimal dose can be added on day 4 or day 5 also. Either 75, or already she has a high LH. We have given anti and started, so we can add some 37.5 also.
Okay, ma'am.
Get it? To get good quality embryos, but then gradually this thing will be
RFSH.
Yeah, it will be, dose will be adjusted. FSH will be gradually decreased and the LH component will be gradually increased. Okay.
Okay. Then same dose is continued till the follicle size reaches 17 to 18 mm.
No, okay. We'll be adjusting the dose, not same dose. Since 225 we are starting, okay. Day 4 we are adding like antag also we are adding. Okay, day 4 or day 5 we are adding LH component also. Usually we'll add HMG only. Okay, we don't add pure LH. HMG which has both FSH and LH. And this will be adjusted. That means it it will become 150, 150. Then it becomes 75, 225. That is HMG is 225 here. Then HMG completely HMG 300 for 1 or 2 days. Finally, we can reach up to maximum, we reach up to 375 HMG, not beyond that. And then we'll give, depending upon the follicular response, if the follicles 3 or more than 3 follicles, more than 17 mm, and that time we will measure the endo E2 levels also, and P4 along with the E2. E2 LH P4 also will be measured. E2 will be in dilutions, and then trigger will be planned.
Depending on E2 level, a trigger should be planned, ma'am. Whether
depending upon the follicular size only, basically. Okay. Depending upon the E2 level, we will think about the OHSS will be thinking. We'll be planning for the, okay. And trigger, yes. If in this case, we'll definitely expect good response, and E2 also more than 3 because she's a PCO picture, right?
Yes, ma'am.
So we'll be giving what trigger?
Agonist trigger will be.
Yeah, agonist trigger will be given. So after the trigger, 34 to 36 hours pickup will be done.
Yes, ma'am. Then, and at the same time during the pickup, and one more PESA sample should be taken.
Fresh PESA will be done for the husband, because frozen PESA, the sperm's motility might increase and even the outcome is a little compromised. So fresh PESA will be done on the day of pickup.
And ICSI is done.
ICSI is done, yes, definitely.
Yes, ma'am. Embryos are transferred, sorry, ma'am. Frozen, embryos are frozen and it is transferred during the subsequent cycles, ma'am.
Yeah. In this case, if that's a PCO patient, definitely we'll go for the freeze-all and frozen embryo transfer, right? If there is good response, no few embryos, we might freeze on day 3 after the compacting stage, cleavage stage, and then we can allow few embryos to grow till blastocyst and then freeze also, depending upon the number. We can decide what to do. And this rheumatoid arthritis, it's not going to affect anything here. What else, Dr. Sangeetha?
Ma'am, what are usually the timings of giving the gonadotrophins and antagonist?
What timings? Huh? Timings of the day?
Yes, ma'am. What time do we plan antagonist and these gonadotrophins?
Whatever time we are starting, no, same time will be planned. It should not cross 24 hours from the next dose. That is the only thing. Because the action is only 24 hours. No, see, for example, today I am starting the antagonist. Antagonist only you're asking, no?
Yes, ma'am.
Yeah. Today, if during my 4 days scan I'm doing, I have decided E2 levels are more than 350. Okay, it has come as 600. I've decided to start the antag. I'm starting antag at 11 o'clock, means daily she has to take antag at the around same time, like 10 to 11, like that only. Only thing is we should make sure when we are giving trigger, the antag, between the antag and the trigger, at least 10 hours gap should be there on the day of trigger. So like in my case, I'm practicing in the evening. So when I'm starting the antag, I'll be starting in the evening. You remember? So it is evening, I'll start around 3 to 5 and daily I'll ask them to take around same time, but I'll be slowly increasing the timing. That means decreasing the timings. Close to trigger, I'll be decreasing. One day she'll take at 3, another she'll take at 2, then 1, 12, then 10. So on the day of trigger, I'll make sure that the timings are between, at least 10 hours gap is there between the trigger and the antagonist. Got it?
Yes, ma'am. And the gonadotrophins and antag are both given together at the same time.
Yeah, we can give. The timings are important for the antagonist, and for the gonadotrophins, around like plus or minus 2 hours.
Okay.
Dr. Sangeetha,
Yes, ma'am. Yes, ma'am.
you are silent. I am also silent. So this case is over, no? So we have stimulated the female and we are going for the PESA for the husband. We are treating. Okay.
Yes, ma'am.
Yeah. Anything else in this case? If the same patient, if it comes as a hypergonadotrophic hypogonadism or whatever, not hypergonadotrophic, hypogonadotrophic hypogonadism, like all the hormones are low.
Yes,
Then,
Then
Actually,
For the man or for the lady, ma'am?
that not for this fellow, for the man. For the
Then
man.
we can give him a cyclical HCG and HMG injections and
Yeah.
try to get some sperms out of him.
After 3 months, yes.
Yeah.
For 3 months, we can try that. And another thing is like that is non-obstructive azoospermia. We can go for testicular aspiration, not testicular biopsy also, and see if sperms are available. Then we can go for ICSI. If not, then they have to go for donor this thing. Okay.
yes, ma'am.
Yeah. So done with your case, Dr. Sangeetha.
Thank you, ma'am.
Yeah. Thank you.
Ma'am, just one more doubt. If we are planning a trigger, we are seeing a high progesterone. Premature luteinization is probably started. Probably that tag was not given properly by someone. Ma'am, what next?
We'll proceed with the pickup only between 34 to 36 hours. We are not compromise. We should be ready for the quality of the embryos might be compromised. Another thing is we cannot go for fresh transfer in such cycles. Progesterone.
Yes, ma'am, we'll not go for fresh transfer, but then we will try a early trigger, na?
Early pickup, you mean?
Ma'am, trigger also probably early because if premature luteinization is started, that means the LH surge has occurred. So we'll do a early trigger.
Definitely, yes. We have to give a trigger early and do a pickup also at 34 hours possible.
We don't plan an early pickup, na ma'am. It will be same.
Pickup will be 34 to 36 hours. We cannot pick up before that.
but ma'am, there are chances that there will be premature rupture also because P4 level has started rising.
Ma'am, what is this early trigger?
Early trigger means just whenever we see P4 is started elevating, just give trigger.
So that is how many hours after?
Nothing like how many hours. Once we give the trigger, we should do pickup at 34 to 36 hours. That's all. Usually P4 we consider like there will be like early luteinization P4, right? And fresh transfers we avoid. If at all we are thinking about fresh transfers.
Thank you.
Ma'am, for to know that early utilization is occurring, that is, we will do the LH levels on day 12th, ma'am.
LH levels we do just to see whether the endogen like LH levels are rising or not. That's all. Once it starts, see, there will be initially day 2 LH is so no. For example, here only in this case, day 2 LH is 8. Okay, on for example, okay, we have given this thing, or we have given antag, and third day LH is we have repeated, it is less than 6. Okay, consider like that. And day 4 or S4 or S5, we will be repeating the E2 and LH. So that time LH is around 2 to 3. That means there is a fall in the LH levels. When close to trigger, we are repeating LH means if it is again rising, that is more than 4 or like that, that means endogenous LH also started rising, then it's the time to give trigger. If it is same, like less than 2 or less than same range, then if we feel that we can wait for one more day, we can wait. If there are multiple intermediates are there, some 2 to 3 or more than 17 and multiple intermediates are there, LH is still low, then we can wait for one more day. If LH is started raising, then we cannot wait, we have to give trigger. That's it. Otherwise, over maturation of the bigger oocytes, we will lose the bigger follicles.
So means, ma'am, when we do LH before giving the trigger, suppose one follicle or two follicles are 17 millimeter, and we want that they should increase, and there are n number of intermediate follicles.
We'll
For
wait.
that, we have to wait because we want the
Yeah,
other
we have to
follicles.
sacrifice. There's only one or two bigger follicles, but there are multiple intermediates. Then we want the multiple follicles only, no, not one or two. We have to sacrifice this one or two to get the other few. We should be ready.
Based on which is more, we will have to give the trigger, and one or two follicles which are mature will be taking out.
I didn't get you. Once again, you repeat.
No, on that day, if we do the LS, suppose one or two dominant follicles are there, and we want to wait because there are other intermediate follicles. But if the LH value comes more, that means we have to give the trigger, and we have to do the.
That is what I'm telling you. That is what, if only one or two follicles are bigger, there are multiple intermediates, but still LH is raising, then still we can wait. Provided this one or two follicles we might lose. That's all. Either they will rupture before our pickup, or there will be over mature oocytes also while picking up. But we'll get the other few. We won't get more GVs or M1s. We have to balance, think. Okay. Sharanya?
Good morning, ma'am. Happy morning.
Happy afternoon, Sharanya.
Happy afternoon. My case is Mrs. X, age 27 years, homemaker, and Mr. Y, age 32 years, working in a private sector, who are residents of Bangalore, have come with a history of secondary infertility for 2 years and 9 months. And they're married for 2 years and 9 months. It's first marriage for both partners. It's a non-consanguineous marriage, and there's no past history of any contraception. And sexual history frequency is about 2 to 3 times per week. There's no history of dyspareunia or premature ejaculation, and they are aware of fertile period. Past history: wife has had a history of rheumatoid arthritis and was on treatment, and husband there's a little past history.
How many rheumatoid arthritis patients are there?
Previous treatment history: in 2020, ovulation induction was done with letrozole, and following timed intercourse, she has conceived and had a spontaneous abortion at 6 weeks. In personal history, nothing significant. In family history, history of hypertension in both the families. Drug history: at present, patient is not on any drugs. Physical examination: wife, height 158 centimeters, weight 75 kg, BMI 30, and pulse rate was 88, BP 110/70, CVS and RS normal, breast normal, spine normal, thyroid normal, and parabdominal examinations, it was soft and non-tender. Perspecculum, cervix, and vagina healthy. Husband, height 168 centimeter, weight 69 kg, and his BMI was 24. Pulse rate 80 beats per minute, BP 110/80, CVS and RS normal. Investigation: baseline investigation done on day 2. LH was 2.07. FSH 4.46, AMH was 0.45, TSH 4.48, prolactin was 12.41, and her hemoglobin was 8.8. Paxil was 27.3. Her OGC2 was 116. Lipid profile was normal. Baseline scan showed uterus was adenomyotic. Right ovary there was a hemorrhagic cyst, and then left ovary there was reduced ovarian reserve. AFC was 3 in left ovary, whereas in right ovary it was not well defined. HSG, there was bilateral periphyseal adhesions, and operative hysteroscopy with polypectomy with laparoscopic cystectomy was done with adhesiolysis, There was the spill there in laparoscopy. There was delayed spill. TB-PCR was negative for her. And husband, CBC was normal, OGCT 116, FSH 4.46, LH was 2.07, lipid profile was normal, LFT was normal. Semen analysis done in 2020, volume was 3 ml, count was 44 million, and motility was 40%. Morphology was 85%. So in this case,
yeah, summarize, Sharanya. So they are young couple actually, right? 27 years and 32 years, married since 3 years or 2.5 years.
With the secondary history of secondary infertility.
Yeah, once
already
they
she is
conceive
conceived
with ovulation induction, once they conceive, you have written as beta HCG positive spontaneous abortion, whether it was clinically documented pregnancy, ultrasound was done, any medical termination or
surgical, no, it was not mentioned.
Not mentioned. How many days? We don't know exactly, right?
Yes, ma'am.
Okay. Then?
So her AMH was low with a AMH of 0.45, ma'am.
Yeah, very low, no? 0.45 is very low. Okay. And thyroid TSH is high. So
is 4.48.
Before you have not mentioned. Okay, TSH is high. I mean high for the infertility patient.
And
hemoglobin also?
8.8. So to correct anemia also. And uterus showing adenomyosis. Hemorrhagic cyst in the right ovary.
No, forget about that
cystectomy was done before.
We don't know what is the AFC on that side also, right ovary, but we might take it as 2 to 3, and this is also 3. So AFC is also less only.
Yes.
Poor reserve, basically, right?
Yes.
Low AMH, poor reserve, young patient. So she falls under which group?
Group 3, ma'am. Positive classification group 3 she'll come.
Group 3 or group 1?
Age is less, ma'am. So group 3. With low reserve, ma'am.
Yeah. Low reserve, group 3. Right. Okay. So AFC less than 5, AMH less than 1.2. Okay. Then, so male factor?
Male factor is
we'll
normal.
consider male factor as normal. So it is here mainly she's a poor responder. I mean, she falls under group 3 with age less than 35 years with
and
low
AMH less
and low reserve. So how will you proceed? But with this only she conceived with ovulation induction prior.
Yes, ma'am.
And okay, so we'll take it as her this thing is anyway. Now we don't want about this. Okay, how will you proceed?
So I'll first treat her. I'll give her thyroxine. I'll start her on thyroxine, ma'am. And I have to treat her anemia also. Then for adenomyotic uterus, we have to get a clear picture. We have to do an MRI whether it is focal or diffuse adenomyosis.
Yes.
And she is present with a diffuse adenomyosis. I'll give her GnRH agonist for 3 months prior to induction.
Now just think about stimulation, retrieving the oocytes first.
Yes, ma'am. I'll start with I have to start with a long protocol, ma'am. I'll be giving her in the luteal phase. I'll be starting with the GnRH agonist, and then on day 3 of cycles, I'll be starting her on gonadotropins, ma'am. I have to start her on high dose gonadotropin as she is a poor responder.
Along with that, what do you want to give?
I want to
because her AMH is low, AFCs are less. So you are starting with high dose gonadotropins. Okay. Then
I have to give her adjuvants also, ma'am.
What adjuvants you will give?
Can give her growth. Can give her growth hormone, but it's costly compared to other adjuvants, ma'am. I have to start her on day 2 or day 3 with growth hormone on with a dose of 8 international units per day.
So 4 international units.
For international
trigger.
day.
Okay. That is along with the stimulation you are starting. Before the stimulation, you want to give anything, Sharanya?
Before stimulation, I'll give a down regulation with OCP in the cycle.
DHEA.
Nice.
DHEA.
Testosterone cell.
Yeah, transdermal testosterone.
Testosterone.
And we can give, right?
Yes,
the prior cycle only. Okay.
Yes, 6 to 8 weeks before stimulation we have to give.
We can start. Yes. Okay. Then, so we have started. Okay. Now we are ready with the stimulation. So you are going to start with a high dose gonadotropins. Okay, because her BMI is 30, 27 years, AMH is low. Okay. How much you want to start? You want to start 300.
Yes, ma'am, 300 for her.
What do you want to start? 300.
Ma'am?
FSH, recombinant FSH? Or you want
both
LH component also?
LH component also, ma'am.
Yes, ideally, yes. So we have to start FSH with LH, we have to start. Yeah, okay.
So we have to monitor the follicle and then we have to give trigger when the follicle reaches the size of 17 to 18 millimeter. And then oocyte retrieval will be planning for OP.
Okay, her expected response, like maybe she developed some two in one ovary and two another ovary. So 4 follicles only expected. 4 bigger follicles we saw. So how will you proceed? What trigger you want to give?
HCG.
Yeah, because it's a long protocol you have used. So definitely it is a HCG trigger. So, and pickup you will do at 34 to 36 hours
36 hours.
How you will proceed with the pickup? Normally we do pickup with a single lumen, right?
Yes, ma'am.
OPU needle. In this case, what you want to do?
Chances of empty follicle syndrome is there in this patient.
Okay.
Double lumen with flushing.
Yeah, double lumen with flushing is preferred. Though the studies say that there is no much difference between single lumen and double lumen, practically we prefer double lumen with flushing technique because we don't want to lose even one oocyte, right?
Yes,
yeah, okay. Then, okay, we have picked. We have got some 4 oocytes. In that 3 M2s are there. 2 are 2 cleaved and growing. So how you prepare her? Do you want to go for fresh transfer or frozen transfer for this patient?
Frozen transfer will be better for this patient.
Why?
We have to because of we have to down regulate her, and
already we have down regulated only, no?
Chances of failure is there with breast transfer for these patients with poor breast transfer.
Why? Because uterus is adenomyotic. That is the only reason.
Yes.
Yeah, but I might prefer fresh transfer for this patient, though uterus is adenomyotic, because we have already on the down-regulated cycle, and we have given HCG trigger. So I might, I like to prepare the endometrium for the fresh transfer also, because we don't know how the embryo is going to behave. We don't know the fate, right? So if there is compromise, I explain everything. Okay. If at all the embryo quality is good, okay, you can go for freezing and then go for the frozen embryo transfer. In that, you can go for the LPDR HRT or down-regulated cycles.
Yes.
Because it is adenomyotic, right?
Yes.
In what
and if there is a poor response, if we are not able to retrieve adequate oocytes, we have to expend them for donor oocyte.
Yes. Or we can you should counsel for the pooled cycle also. Sometimes we might get only one embryo. Okay. So if the embryo is good quality, we can even counsel them for the pooled cycle. We can stimulate and go for the other pickup and pool the embryos and transfer also. That is one thing. And what about this dual stimulation or double stimulation methods? For the poor responders?
This they give clomifene and letrozole together, ma'am. They talk duplex protocol. We'll retrieve oocytes at 2 times in a single cycle, ma'am. Duplex
protocol or Shanghai protocol.
Shanghai protocol, we
both in follicular
give
phase and luteal phase, there will be stimulation and retrieval of the oocytes. So first pickup will aspirate only the bigger follicles, leave the smaller follicles. We don't try to aspirate all the follicles, and that will
then
be
we give gonadotrophins again, and then we give antag and then retrieve again.
Yeah, and then pull the embryos and then transfer. So for such poor responders, okay. If we get all empty follicles, or the like whatever M2s we got, no, either they didn't develop, they didn't grow.
So we have to plan for the
yeah. We should counsel them for the donor cycle. Donor oocytes with husband sperms. And then transfer. Okay. So, anything else, Sharanya?
Ma'am, I have a doubt. This patient had adenomyosis and she had a poor ovarian reserve. So if we give a agonist in advance and then plan a stimulation, will we not require higher doses? So can we not stimulate then prior to transfer, we should give the agonist rather than giving a long agonist cycle?
Because of the poor response, she has this thing, no, low reserve. Sometimes there will be asynchronous allotment of the follicles also. To do that only, we are going for this lupride cycle.
But ma'am, we say that estradiol in the previous cycle gives better response for poor responders rather than agonist.
Yes, either estradiol or even just plain OCPs also in the prior cycle. We can give and start with the normal antag cycle only. We do that only. Just routine antag cycle only we prefer with the prior treatment of OCPs or the estradiol.
Yes, ma'am. So we'll avoid the actually long agonist protocol.
Long agonist, one is long, another one is that the demand for the gonadotrophins also will decrease. In long agonist protocol, the demand will be more. So they consume more gonadotrophins for less number of oocytes.
Yes, so we should give agonist actually only prior to.
Okay. Anything else?
Ma'am, there is one more query. Like both the patients have had rheumatoid arthritis. Both have had a biochemical pregnancy loss. So should we think of autoimmune disorders and also investigate on those lines before starting the stimulation? Because RA itself is autoimmune and then they both give history of biochemical pregnancy
nothing
loss.
Wrong in evaluating for that also. But only thing is it's only one loss.
Yes.
Yes, one loss. That is why. If it is 2 documented losses, yes, definitely there is no need to. It's only one loss, and this one we don't know whether it is biochemical or, but anyway, it's an abnormal pregnancy outcome only. If we want, we can, because both that rheumatoid arthritis autoimmune disorder is there, we can evaluate also. We should counsel the couple about that also.
Or post-transfer, do we routinely put steroid and heparin and ecosprin for such patients?
Yes, routinely we put.
Ma'am, for poor ovarian
only for rheumatoid arthritis
protocol, ma'am.
What?
For poor ovarian reserve, minimal stimulation protocol cannot be followed, ma'am.
Can be followed, definitely yes. All poor this thing can be followed, like long protocol, minimal stimulation, or even the double stimulation, dual stimulation, Shanghai, anything can be followed. Expected oocyte number is only less actually. So there, if we go for the minimal stimulation, the cost also will come down for the patient.
Ma'am, donor oocyte, like how it is, ma'am? It is, we have to first only book with some patient or some center, ma'am?
Yeah, there are registered centers actually. So they will send the donors depending upon the, we have to match the patient qualities with that, mainly the blood group, height, color, that and all we have to match. And then based on that, we will be picking or choosing the donor. If the response is good, and there should be a documented healthy baby with them. And we will evaluate also. And then we will choose the donor. We don't prefer PCO, dense PCO donor, we don't prefer. We prefer adequate reserve donors.
Ma'am, it is only blood group, height, weight, ma'am.
Yeah, mainly.
Ma'am, it is only blood
And
group,
religion
height, weight,
also. And religion also. Because their patients will be,
okay.
A few patients, they're particular about few things, so that we have to match.
Okay, ma'am. Thank you, ma'am.
Yeah.